general, as we pointed out before, the veins in general correspond to the names and the transit of the arteries. Although in the face, there's more divergence than you will find elsewhere in the body. So once again, make sure that you can identify the maxillary vein and the facial vein and so on. We should point out, and you probably heard this since you were in high school, that in this region, all these vessels, the blood in these vessels is in various ways continuous with the blood inside the brain. And so any type of infection outside in the skin or whatever, any type of wound can be a source of communication of the infection into the brain case. Well, not just, you're exactly right. If we're talking emissary veins, if we're talking about the skull, but I guess what I want you to realize now is that as we get into this region down here, which is sort of between the head and the neck, all of these venous structures are heavily anastomosing. For example, the internal and the external jugular all sort of feed together in this region, branch together. So I think we left off with this slide. We were pointing out that the drainage is going to be, at least for the extracranial drainage, is going to be into the external jugular, which is down here. And you can see the superficial temporal and its branches. These are the veins. And for the most part, the terms, the vessels correspond to those of the arteries. You have the transverse facial here, you have the maxillary there, you have the facial vein here. But where things change is right there, right in this region here. Excuse me, because for some reason, some brilliant anatomist decided that this vessel, and this vessel, these three vessels here are all just one vessel. We call them the retromandibular vein, retromandibular. And so you can see there are three branches of the retromandibular, sometimes called the superior, the posterior, and the anterior branch. You have a better, at least a larger image of that here. So this is the all of this is retromandibular. Again, this is sometimes called the superior, posterior, and anterior. Also in this image, getting back to our discussion of how all of this venous circulation between the internal jugular and the external jugular sort of comes together in this region. You'll notice here, this plexus, this venous plexus here is called the pterygoid plexus, and it pretty much resides between the two pterygoid muscles. It's connected or joins up internally or interiorly with the internal jugular, which, as you know, drains most of the dural sinuses. And it's actually connected with the cavernous sinus as well. But you can see it empties more directly into the maxillary vein. And then the maxillary goes into the retromandibular system. Yeah, that's what I'm trying, yeah. And that's not the only point at which that occurs. You have a number of veins down here in the neck that also sort of interconnect the internal and external jugulars. Yeah. Yeah, this is the pterygoid plexus here, and if we had a we didn't have the bones, you would see that the cavernous sinus and some of the other interior cranial venous structures, the dural sinuses, empty into this. Now, most of that blood goes into the internal jugular, but you can see the pterygoid itself anatomically is draining into the maxillary, which in turn drains into the retromandibular. So there's a confluence of blood between the internal and external jugular. So we'll come back and look at some of these. We're going to look at the parotid gland. I just want you to see the relationship here, for example, between the the branching, the superior branches of the external carotid, and then this superficial temporal vein, which eventually will become the retromandibular in this region. And you can see the relationship between the facial artery and vein here. A couple slides here, I think just one, I guess, on the lymphatic drainage. In general, lymphatic drainage in the head is going to be important for you. We won't spend too much time in here, but oftentimes the lymphatic nodes and vessels can be indicative of a variety of pathologies. In general, you can see that the lymphatic drainage is from central to peripheral and from superior to inferior. So in the head, the lymphatic drainage is generally toward the base of the skull in the region of the neck. All of these lymph nodes that you see aggregated around the jugular there, these are cervical lymph nodes, and most all of the lymphatic drainage then moves in that direction. And then this will go into all of these nodes will empty into what's called a jugular lymphatic trunk. You don't really see it very well here, but the jugular lymphatic trunk then empties somewhere. It varies from individual to individual into the what's called the venous angle, where the vein and the subclavian come together in the brachiocephalic.
So it goes from deep to superficial?
Yeah, deep to superficial, in the head. So in other words, it's draining out toward the periphery and then down. What you can see, again, you don't really see it very clearly here, but this jugular trunk that sort of parallels the internal jugular vein. Yeah, in general, all of this, and you just have to accept the enormous degree of variability here. All of this lymph is going to drain in the region of the venous angles, where and it won't always be at the angle. Sometimes the drainage in an individual may be into an internal jugular vein. It may be into the subclavian. It may be into the brachiocephalic. It may be into all of those. So there's a great deal of variability. All right, we want to look a little bit at these glands. We've talked about these. We've talked about their innervation in the for your previous test. We talked about the parasympathetic ganglia that are present in the head that permit salivation. This is the parotid gland. For the most part, we're looking up here. This is the parotid. You can see portions of the submandibular as well. We have a better picture of that. The problem with the parotid, from your perspective, from a medical perspective, is that this is a gland that overlies a variety of other critical structures. I think you can recognize from our previous graphics, our previous illustrations, that there are a number of important structures right back here. We've already talked about, for example, the external jugular, the parotid, but perhaps even more perilous is that, remember that I think it was a question on your quiz, the facial nerve. It emerges from below the ear and then reticulates. It branches through the parotid so that if there is any pathology of the parotid, one has to be very careful not to involve or damage the branches of the facial. Here's the parotid duct. The parotid duct empties just there behind the molars. Let's see a better illustration of that. That's the parotid duct there, and you can see the relationship to the parenchyma of the gland. Again, down here is the submandibular. These glands can sometimes become inflamed for a variety of reasons, and once again, they can actually become cancerous, and for a variety of reasons. Therefore, one has to become very careful in addressing it surgically. Here's the
Go back a couple slides to the original parotid model. That's okay. Thank you.
So here you can see the branching of the facial nerve through the mass of the the parotid. And you can go on the internet and you can find probably a dozen different videos by surgeons bragging about how successful their surgery is in removing portions of the parotid without endangering the facial nerve. They usually, as you know, will name the procedure after themselves and then put up a Google video on YouTube or whatever, and they're guaranteed immortality. I do that every day after class. We've already talked about the branches. I'm not so concerned, but this is just pointing out that all those critical branches of the facial nerve radiate from that stylomastoid foramen into the partially behind and partially through the parotid.
We'll take a more complete look at the facial nerve in the next tape in the series. Here, we're concerned only with its relationship to the parotid gland. Now we'll add the superficial part of the gland to the picture. Here it is. The superficial part of the parotid gland covers the posterior part of the masseter muscle. Its extent varies. It usually extends up as far as the zygomatic arch and down to the angle of the mandible. It can also overlap the anterior border of the sternocleidomastoid muscle. The saliva that's secreted by the parotid gland passes into the parotid duct, which emerges from the anterior border of the gland and passes forward around the anterior border of the masseter. The parotid duct enters the oral cavity by passing through the buccinator muscle and through the underlying mucous membrane at about the level of the second upper molar tooth.
Now, this is just an illustration. Remember, this is a gland. It's as glandular tissue. It's creating a filtrate of the blood that we call saliva. If we have time later, we'll talk about all the wonderful things that saliva does. But this is just to illustrate a typical morphology of a salivary gland. And as I've indicated, these can become infected, they can become inflamed, and they can also become cancerous. And again, those would be the primary issues you would have to deal with. This is just a discussion. Here it's called an acinus. Remember the little morphological distinction we made earlier? Well, again, this does not correspond to this. So you can see how frustrated I can get when these terms are used in a variety of ways. But that's simply to remind you that this acinus, don't you agree it looks more like an alveolus? So, sort of an illustration showing the branching of the facial through the parotid again. Oftentimes when the tumors are present, either some or all of the parotid will have to be removed. But ask yourself, why is it pulsing like that? Of course, you can see the facial nerve, and you can see portions of the parotid there. And of course, why was it pulsing? Yeah, what vessel is behind there? We talked about the carotid, yeah, the carotid's running right behind there. And so you can see the external curve. This is the only purpose of this slide is just to remind you of those very important structures, that both the parotid and the retromandibular all are right there, intimately intertwined with the parenchyma of that gland. You may be involved in cialograms. What's the other word here? Anybody want to give that one a try? I think you're right. Cialolithiasis. And that would be a removal of at least a portion of the gland. And the cialogram is just a sort of a specialized X-ray that allows, it's usually a stain or a contrast dye is involved to help to identify any abnormalities in the gland.
So her eyes, it's just being removed from her.
Yeah, if you notice the title of the link here, it says, "This monstrosity was pulled out of someone's salivary."
Yeah, it's a lip. It's a stone, yeah.
Yeah, sort of what will sometimes happen is that in that parotid duct, a concretion, a lith will form. And that, depending on where it is, sometimes they can remove it from the little, this can happen in the submandibular, it can happen, I've never heard of it happening in the sublinguals. But in the parotid, sometimes they can go back there and open the channel and sort of extract it. They'll use vacuum procedures or some other more sophisticated surgical procedures. But yeah, this would be a concretion blocking usually one of those ducts. All right, that's that. I just thought we'd finish here by looking at some of the amazing things that are now happening in this field. We're talking about the face. Anybody seen this fellow before? That's a full facial transplant.
Mr. Richard Norris, only 6 days after his surgical procedure.
Richard Norris, a man who received a full face transplant in 2012, recently shared some stories about his life before and since with GQ magazine. When Norris was 22 years old, he suffered an accidental gunshot wound to the face.
You can see the individual as he lived for 15 years of his life behind the mask.
Even after surgeries, his features remained mangled and compressed. His lower jaw had all but disappeared. He became a recluse, living with his parents in their Virginia home. His life changed when his mother discovered Dr. Eduardo Rodriguez, a reconstructive surgeon. After several procedures, Rodriguez determined that Norris was a perfect candidate for a face transplant. The procedure took place in March of 2012, and the results were not only successful, but have been life-changing. Norris has since taken several online classes and embarked on a new romantic relationship. He still has struggles and admits to self-medicating with alcohol. The face, however, is something he's comfortable with. He said, "When I look in the mirror, I see Richard Norris."
To me, that's a fascinating observation. We won't look at all of these, but here's some other examples.
To her face, so much destruction of the bone.
This was a rather remarkable case because of the amount of skull damage.
Today, as Dr. Sanjay Gupta tells us, Culp is ready to meet the media.
I tell you, this is one of the most remarkable things I've seen as a reporter and certainly as a doctor as well, trying to fix a woman's face after the horrific injury she had. This is Connie Culp, 46-year-old mother of 2 from Ohio. She was shot in the face. Let me tell you some of the things the doctors first looked at here. Take a look at these CAT scans. First of all, the CAT scan on the left, you can see just how much injury she had to her face, so much destruction of the bone. If you strip away some of that and look at this particular image, you see just how much loss of tissue she had as well, and what the doctors had to work with. After 30 operations, significant operations, this is what they were left with, a significant band of scarring across the middle of her face. Her nose is essentially closed. She's unable to breathe through her nose. She's unable to eat on her own, unable to take a sip of water from a cup. Just a horrific injury. But most importantly, this is what we saw today after an 80% facial transplant. Take a look here. A front-on shot, a side shot. Very different woman. Notice that she does not look like herself, obviously.
Now, he says that, but in all the cases that I've read about, when they ask the individual with the transplant, what do they look like? Who do they look like? Don't know if this is something they're supposed to say or whatever, but almost invariably they say they see their original face. Now, I don't know what that means precisely, but they have no trouble identifying with whatever they see in the mirror at this point. In any case, remarkable case there. I thought we saw a picture of her walking.
There's a lot of swelling. She's still very much
This is what they project.
Post-operative sort of phase of things. They think that swelling is going to go down, and she's ultimately going to look like this. It's worth pointing out she doesn't look anything like she did before the injury that she had, the gunshot wound, and she just.
Oops. And then there's this fellow who was earlier, I think. Oh, this is the man.
Shows her new face off to the world. Carmen Glandon Tarleton has been on what she has called an incredible journey for the last 6 years.
I think she lost all of her sight.
This wonderful gift and this chapter in my life.
Back in 2007, she suffered a disfigured face and body after her estranged husband threw industrial strength lye over her. It burned through more than 80% of her body. Since then, she has endured 55 operations before deciding.
So it's remarkable, and I thought there was another one with one of the male transplants, and there was a little line in there. He doesn't look as good as the first fellow, but his little daughter said that she thought he was extremely handsome after the transplant. All right, then let's move on and talk a little bit about the region of the mouth and the oral cavity. We're looking, I guess you see this all the time, but my gaping mouth open all the time. But here's the anterior opening is called the oral fissure. Oral fissure. Fissure just refers to the opening usually between two occluding portions of the opening. The eye openings are also called fissures. And then the posterior opening is called the oropharyngeal isthmus. Oropharyngeal isthmus. So we're really concerned at this point with what lies between these two. We'll look at the roof of the mouth. Of course, the roof of the mouth consists of both the soft and harder components. You already know the skeletal framework. And then I think in terms of general function, you have no trouble understanding the functions of the mouth, everything from digestion and secretion, initial processing of ingesta. There are enzymes in the saliva that pre-process the food, everything from lingual to lingual lipase to amylase, very important for vocalization and speech. And then curiously in primates also, well, when I say primates, there's an inlet for breathing, but our GI tract and our breathing tract come together in a rather precarious way that presents special problems and sometimes special opportunities for you therapeutically. Again, some of the terminology to be familiar with looking at the sort of the external structures here. There are a number of structures usually called the frenula, or the frenulum is single, frenula is plural. I think American English frenulums is accepted too. But these restrict the movement of the tissue. So, for example, there will be a labial frenulum on both the upper and lower lip. And then there's one for the tongue as well to restrict superior movement, sort of a connective tissue. We talked about the parotid opening there. There's the parotid papilla. Down here at you can see the tongue is elevated. The tongue's pushed up in that direction. And then down in this region, if you maybe pull out your mirror or look in the mouth of the person sitting beside you, you will see a variety of little ridges and openings there. And these are the openings. All of this little ridge here are the openings for the sublingual and submandibular glands. Notice that a portion of this is called a plica. A plica is just a ridge or fold. So this entire little mountain here, this entire little hill is called the sublingual plica. And then you have medial to that, and right and very close to where the submandibular gland releases its secretory product, the sublingual caruncle. The caruncle is the preferred pronunciation. And the caruncle is just a little prominence.
You said that was the sublingual salivary gland?
Yeah, that I guess and I was looking for a better illustration. I just didn't have time to get this in. This gets very confusing in here. But again, you can see the ridge here. And in fact, what I'll probably do is just put another illustration up on the main page or something, because I'm not really happy with any of the illustrations we have. So this ridge right here, you can sort of see little openings here. These are openings for the sublingual. Then there's an opening here of the sublingual. And then again, if you can do this right now, if you wish, or have your assist your classmate, if you look inside your mouth and open your tongue there, you can actually palpate the base of your tongue right there by the frenula, and you can see little saliva squirt out at you. That is submandibular. So they're all jammed in there together, but that little ridge is sublingual. There are a number of facial terms, descriptors that you will learn about in more detail later. For example, we talked about the oral fissure. Just wanted to make reference to the what's called the philtrum here above the mouth, that little furrow you have right here. That is often diagnostic of a number of genetic diseases. Either it's too wide, it's too narrow, or it's too long. This is a deletion syndrome we're looking at here. These are two different individuals, but they exhibit two characteristics, two facial characteristics that are present in these individuals. Very long, broad philtrum, and then something called facial hypoplasia. Facial hypoplasia, which means that the region of the face, in this region of the face, did not develop fully, or normal, I guess is the term, what would you find normal? So there's usually either a flat region or a depression, where there should be more of a rostrum in the human face. So this is the oral cavity. You see it from a variety of vantage points here. The oral cavity is also called the buccal cavity, and we talked about some other terms to describe this region. This is the very critical region where the digestive system and the respiratory system sort of come together, and as I say, can create problems and opportunities with respect to therapy. We're going to call that the oropharynx. There'll be some other slides here where that's more thoroughly named. All right, so we're still peering back into the open, gaping maw here, and so in this image, his tongue is sent up down here. We're looking at the flattened tongue at the base of the oral fissure, and notice that the top of the tongue is called the dorsum. Back here, toward the oropharyngeal isthmus, you'll notice the uvula, which is just a little projection of muscle that is covered in mucosa. And then all of this, these structures back here, are the fauces. I'm sure it's there somewhere. The fauces. And again, there are multiple illustrations of this, but the fauces basically consist of an anterior palatoglossal ridge or arch, anterior palatoglossal arch, a posterior, that would be it back here, a posterior palatopharyngeal arch, and then between the two, you don't really see it here, I don't think. Yeah, you kind of should. Between the two would be the palatine tonsil. Collectively, they form the fauces, and I would guess that, well, I don't know that I want to make a generalization like that, but what we are looking at in that structure is the oropharyngeal isthmus. Let's see, anything else here? You know the term raphe. Raphe implies midline, so that there's the palatine raphe. The gum around the teeth, the conchoses, is called the gingiva. I think we talked about this before. There's a transition zone in lips here, going from stratified, keratinized stratified squamous to non-keratinized stratified squamous. So here's that oropharynx again. You can see the large tongue here, the hard palate here, the soft palate here. Most of this is muscle tissue and mucosa. In this sort of coronal section here, what we're calling the buccal cavity is actually buccal or oral cavity proper. That would be all of this in here. Then where the teeth come together, where the teeth occlude, that's sometimes called the dental arch or the dental arches. And then lateral to that, this opening over here, where you keep your bubble gum and stuff, that's the oral vestibule. So oral cavity or buccal cavity proper here, and the oral vestibule here. Now we mentioned the fauces, we mentioned the oropharyngeal isthmus. Here's that palatoglossal arch, and so you can, and remember that's the anterior portion of the fauces. And so there are a lot of there's a lot of musculature right here in this soft palate and here too, to make sure that this opening or this tube opens when it should and closes when it should in relation to the cycle of breathing and digestion. Yeah.
The posterior wall of the oropharynx, the palatine tonsil, and the palatopharyngeal arch form the
Fauces.
palatine fauces, or just
No, just fauces. Yeah, there's a palatine tonsil, but it's just the fauces.
how do you spell that? F-O-S?
F-A-U-C-E-S.
Oh, F-A-U-C-E-S.
You have several, somewhere in there somewhere. So we're looking at the walls, we're talking about the walls of the oral cavity here. And what we're looking at here is this muscle highlighted in purple there. So we can go back here. It's this muscle called the buccinator. Is that going to be a superhero one day? And the buccinator, we said, is important for holding the wall of the cheek against the teeth when you're chewing. Because that can be perilous if you've been to the dentist and have been anesthetized in that region. But it's sort of to control the allocation of food between the vestibule and the buccal cavity proper. It eventually joins up with portions of the orbicularis, and the orbicularis is going to be present around the lips and extending into the lips, but that buccinator will tie into those, and will also have some anchors in the surrounding mandibular and maxillary bone as well. The buccinator is innervated by buccal branches. Buccal branches in the case of motor from 7, and for sensation from the mandibular. One last thing before we leave the buccal. Notice the orientation of the fibers, generally sort of perpendicular to the anatomical axis. I don't think we're going to talk about some of this in more detail, especially with respect to innervation of the tongue. But I've put this slide in here just to summarize some of the important points with respect to sensory innervation. Virtually all of this involves the cranial nerve 5, upper cavity V2, lower regions V3. And then don't worry too much about the discussion of tactile and taste sensation, because we have some better graphics to explain that. I think I have some images a little later that will make that a lot clearer. And then, of course, there's also parasympathetic innervation in this region to the salivary glands that we need to remind ourselves of. We'll do that in a moment. With respect to the motor function of the tongue, remember that's almost all hypoglossal, except for one of the inferior tongue muscles, the palatoglossus, which is innervated by the vagus. And then for the soft palate, these very delicate skeletal muscles that play such an important role in coordinating the swallowing process, the deglutition, and also timing the relationship between breathing and eating. Most of those muscles are innervated by the vagus, except for this one, the tensor veli. The tensor, there's also another veli, but the tensor veli is mandibular. So again, just some general rules to simplify our appreciation of the innervation. I've actually put this one up. If you don't have it in your slides, it's fine. Probably better. Because you can see it's just a confusing mess. But this is someone's attempt. I wanted to just sort of adumbrate or mention this now, and then we'll come back to it. You have a number of other illustrations showing the same thing. But here's what I wanted you to pay attention to, a few things. We've been talking about the innervation in this region of the salivary glands. And it's a little bit complicated. Here's the submandibular gland down here, here's the sublingual. Here's the mandibular right here. And you'll notice that the mandibular gives rise to a nerve called the lingual nerve. The lingual nerve then is a branch of V3. The lingual nerve, which is a branch of cranial nerve 5, the mandibular, then joins with a branch of cranial nerve 7 that joins with what's called the chorda tympani, which is a branch of cranial nerve 7. I think in general, we continue to call this nerve the lingual nerve, but at this point, notice that it contains branches of 5 and 7. Now, what are they doing? If you look at this illustration here, they're actually, you can see there's a dashed line and a solid line. The solid line are parasympathetic efferents. The solid line are the efferents for these glands. And they come from cranial nerve 7 via the chorda tympani. Running the other direction, and as I say, don't worry about the details of this right now. I have a better illustration to make this clear. Are the taste sensations from the tongue? Remember, the tongue provides you with pain, tactile sensations, and taste. So notice the taste then is coming back through the lingual nerve once again into the chorda tympani. So I guess what I'm saying here is I'm trying to introduce these terms that we'll see again in just a moment. Lingual nerve, chorda tympani, and then just have a general appreciation of the fact that these nerves are involved. Remember, cranial nerve 5, is it sensory or motor? Yeah, but which branch of cranial nerve 5 is motor? Huh?
3.
Yeah, and so that's the one that we're looking at here. Facial nerve, is it motor or sensory? Mostly motor, but it's sensory in that it's doing what? Yeah, taste sensation of the tongue. And if that's not enough to addle our brains, we have to deal with the autonomic pathways that are passing through. I just want you to begin the process, and we'll try to hit it a few different times to make sure this all fits together. Somebody have a question? Yes, sir.
So those two branches join from different nerves, but it looks like 7 is the one responsible for doing all the communication.
Yeah, we know. That's why I'm not sure exactly what to say about this region. We continue to call this the lingual. In most books, it's still considered part of the mandibular, but you should be aware that at this point, where these two come together, it's really 7 and 5. The lingual nerve is not merely a branch of 5.
Is that what you would term piggybacking?
Well, certainly when I talk about piggybacking, I'm talking about, the autonomics on top of the somatic cranial nerve. And that's exactly right. That's exactly what it's doing. There's another more subtle point to be made there, but let's not worry about that now. All right, so this is just to remind you that you need to know, and I think you already do, you need to know the bones that frame the oral cavity. So I think you're familiar with all the bones mentioned up there in the top right, and you would have no trouble localizing those, identifying those in a sagittal section, such medially sagittal section such as this. And you have already been tested on a figure like this, so this should not be a problem for you. But again, this is where it's this region right in here where the respiratory and the GI tracts come together. Where we talked about the pterygoid wings and the pterygoid plexus, all that's in here. The term styloid process is one of these anatomically frustrating terms because you're going to have other styloid processes to deal with later. You have styloid processes in your wrists. But this styloid process attaches to the temporal bone. And it's going to be a sort of a needle-like or bony projection specifically for muscle attachment. And it's important for attachment of lingual muscles, more precisely lingual tendons, but also at least several of what we're later going to call, when we talk about the neck, the suprahyoid muscles. And supra means above, and we're talking about the hyoid bone. And all of these, sometimes they're called strap muscles or hyoid muscles, they're going to be very important in moving that hyoid bone to facilitate swallowing, facilitate speech, breathing, and so on. But here, as Zachary would say, here's the styloid process of the temporal bone. I think we mentioned that sometimes that can become a little longer. I think we talked about this at the beginning of the term. This is an elongated styloid process. That's called Eagle's syndrome. And sometimes it's the individual's born that way. Sometimes for reasons that aren't clear, it'll just grow long. Sometimes following endocrine changes or sometimes following surgery. And the patient often presents with pain with head movement, dysphagia means difficulty swallowing, and then sometimes follows tonsillectomies. With respect, so we talked a little bit about the walls, we talked a little bit about the roof. Looking at the floor of the oral cavity, so you can see it's mostly tongue here, and that's the prominent component of our floor. But as we move south from that, you'll notice there are several, there's something called the paralingual space. We won't worry too much about that, filled with vessels and glands. But I do want you to start looking at some of these muscles that are going to be critical here. This muscle right here that forms that V-shaped structure, that's the mylohyoid muscle we talked about before, that forms that palpable floor of your chin there. And then just above that, at the median level, is another one of these suprahyoid muscles called the geniohyoid. So this is the mylohyoid, and this is the geniohyoid. And below that is another hyoid muscle, the digastric. And then we'll talk about the muscles of the tongue in a little more detail later. All right, let's take a break there.